All right, we're getting into really the guts of this whole lecture is finding your pelvic floor. And one of the ways I have of doing that and helping people is through biofeedback. Biofeedback is a software program I have in my treatment room where I hook you up with these little sticky things on your bottom, and then I ask you to contract. And it will give me a waveform on my program to let me know how well you are doing that. That tells me where to begin. I also do a manual test. Vaginally, I will come in and test your muscles with my own fingers and just have you squeeze, and I will put a grade to that. And that, with the biofeedback assessment, will give me an idea of where you are. Are you super, super, super weak? Or are you just medium weak? Or are you better than we thought? So I have some concrete objective data to tell me how well you are with your pelvic floor muscles, these guys. And then from there, I can come up with a program. Now, a lot of the books will tell you, go home and do 100 Kegels a day. Well, I have to tell you that that's not the advice that for some women, I'd say the majority of women can do that, but for some women, their pelvic floors are so tight to begin with. They might even have pain on intercourse. They might have other pain in the pelvic issues. You know what trigger points are in your muscles? Trigger points are places of hyper-irritability that if somebody like me comes along and presses on it, really, really hurts, and you had no idea that it hurt like that until someone just puts a little pressure on it. And then, it all has to quiet down for those people before you can begin to strengthen it. It's not efficient to allow for the strengthening. So that's what I look at when I see you in my office. That's what I look at. The integrity of these tissues first, and then I know how to put you on a program. For a lot of us, you can go right into working on strengthening, find your floor. What I just talked about were some exceptions to the rule, and they do exist, depending on this cumulative history that I'm talking about. But everybody sit with their feet on the floor, okay? And we're going to learn where these muscles are. We're going to go by feel, by how it feels. And posture is important. We have so much of our lives where we're like this, depending on what we're doing, including massage therapists. And computer people, and we're just kind of slumped over. We're just this forward posture. What am I doing? Putting pressure down here, aren't I? Because I'm bent. When I do that, they are at a complete mechanical disadvantage because I am pressing over, I'm forward on it. So when you start an exercise program, your trainers or people working with you, they gotta make sure that you are up, you're sitting up, you're tall. And for you and me, it's sitting right on your sit bones. You know where your sit bones are? Your ischial tuberosities. These guys right here. And you know you're on them. If you're not slumping, don't be too far up straight, rigid. You want to be right there. And this is a place where mechanically you have an advantage if you're sitting right on your sit bones right here. Okay? So I said before, your pelvic floor, I treat it in 3 layers. Urethral, where you stop the flow of urine. Then there's vaginal. And then there's anal, where you stop as if you're going to pass gas. You don't want that to happen, so you squeeze your anal muscles. So let's call it the U, the V, and the A. UVA. Does that ring a rah, 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 Mary? Okay, so you find that muscle. It's subtle, guys. It's really subtle. But find the muscle right now where you are contracting as if you're stopping the flow of urine, and then let it go. It's in the very front of you, right? You don't squeeze your glutes, don't squeeze your abs, don't tighten your jaw. just find that as if you imagine you're stopping the flow of urine. That's it. A little bit behind that is vaginal, where you give it a little bit of a squeeze, as if there's something there, and you're squeezing it up, lifting it up. And then anally, you have an anal sphincter. No glutes here. And then that's hard. Give it a try, Lisa. Anally squeeze only that sphincter as if you had gas, you don't want to expel it. And let it go. If you can differentiate that, if you can't, don't worry. Feel the best one you have. When they gave us Kegels how many years ago, all they talked about, squeeze as if you're stopping the flow of gas. You don't want to expel gas. And that's all they said. But in the more recent research, they've learned a boatload more about these muscles and how they actually do work. And I've narrowed it down, and I've experienced this. I've had people work on me internally to find these muscles, and I've experienced, and how many women I've done this with, I see a difference in strength between the A and the U. And someone says, oh, I'm leaking all the time. Okay, well, let's see what your urethral, these muscles, they're different muscle groups, and I can identify all of them. But if you can squeeze as if you had the flow of urine, say that's all you got, okay, then we just keep working from there. But hugely important is your awareness that where these muscles are, and it's not everything else. Now I want to impress upon you, all of these pelvic floor muscles neurologically are on the same loop as your abdominal muscles. We have our glutes that also assist these muscles. We have our strong adductor muscles inside. Maybe there's this thing on TV you saw where this woman puts something between her legs and she's doing this to get to her pelvic floor. It's strengthening her adductor muscles. It's an accessory muscle to these guys, all right? But I like to nail it. I like to say, this is the muscle we have to focus on. Let's use it. Then I'm going to put it together with adductors, abs, glutes, because these guys are all accessory to these. All right, that makes sense. So if you learn with me, that's your UVA. Rah, 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 Mary said. That's your UVA. All right, and you just focus on doing that. How many times a day? I just say for a group, I don't know your individual problems, but as a group, and as I am getting older, every hour I will do at least 10. Am I doing these? Yeah, I'm doing them. Every hour I'm going to do at least 10 UVAs. And you get quicker. You get a little faster with it as you find it. The key is finding it first. UVA, UVA. And you just try to do that and see how you do. Most people will come back and say, you know, I can actually feel it now. You got to actually feel it. Like you would feel your biceps contracting. You got to feel it, but the brain has to tell it what to do. And so the most important is awareness of where these muscles are and how to engage them. So let's just say every hour, whether you're sitting is better and lying down is better. You feel it better. Standing is harder to do because you have gravity. It's like, can I find it? Can I do it? You will also notice too, if I say 10 times in an hour, maybe by the time you get to 4 or 5, they feel fatigued. You just don't feel it as well. Give it a rest. Wait at least 10, 20 seconds, and then go back to see if you can do the other 5. You have to have a rest phase with a contraction. Any exercise physiologist will tell you that when you're working a muscle, there's a contraction and a relaxation phase. At the relaxation phase is when the muscle regroups and gets its energy to do the next bit of work. All right? So that's what I would like to see you do. Now, when strengthening the muscles, oh my gosh, you can advance with it. Some physical therapists will give you weights. Can you imagine? Give you weights, you know, like resistance with. I just want you to know what these look like. You put this inside like you would a tampon, right? And then you walk around kind of holding that thing in. And if it falls out, well, you start over and try again. You know, but I don't use these things because most women I see have pain someplace else as well, you know, in their backs or their hips or something like that. But when you see the ad on TV or you see somebody says, well, let's go to some vaginal weights. Okay, I don't think I want to do that. But this is what it is. It's just a weighted, here, you can feel it. It's just a weighted little cone that fits in there. And your muscles are supposed to close around that and hold it. That's a static contraction, isn't it? I mean, if you lighten up and just relax, it's on, you know, what?
How long do you hold the contraction?
What?
How long do you hold it?
Well, you start off with, that's a good question. You start off with just find the muscle, your UVA, contract it, release it, contract it, release it. As you advance on the program with me, I'd say hold each contraction 5 seconds. And some women know they lose it after 2 seconds. I can't hold it. That's what biofeedback is helpful for. If I have you do a contraction, I'm going to show you biofeedback. We're going to all go back in that room, and I have and Amy's going to be our cooperating person to show us what that looks like. So 5 seconds. Then after that, you progress to standing, working your floor, functional activities, working the floor, squatting, work your floor. I mean, there's a progression of, there's levels to progress to, all of which you do by yourself in your home. That's what's really cool, okay? So, and how you progress depends on how well you're doing this level. Then you progress to the next level. So in her book, The Bathroom Key, she progresses you and she tells you how far, you know, what the next level is to go. And if I saw you individually, checked out everything in the pelvic arena that's not painful, the tone, are you ready to actually exercise? I have women who cannot begin to do the Kegels until their tone of their floor has improved. By tone is the tightness, it's how your muscles feel. You know, it's just, they have to be efficient before you can do the work. So I think one of the other things that I also use, this is really fun, is a periometer. Someone says, well, I want to know how well I'm doing on my own home program. It's called a PMTX. And you could use this at home as your own little gauge. This has been around since 1940, I can tell you. And what you do, you insert this vaginally, and you can squeeze it. If you squeeze that, the little ball, is it going up?
Oh, yeah.
It's going up. If you squeeze that, you can, so your pelvic floor muscles tighten around this, and you can gauge how well you're doing. Just your own little thing at home. Periometer, PMTX. He says it's been around a long time. And it's just squeeze. Soap and water, put it away, put it under your pillow, whatever, and just come back and just, when you're ready for your practice session. In the meantime, you're doing this once an hour thing, and then every once in a while, maybe once a week, every other week, you come back and say, how well am I doing? The important part with this is that, yeah, I can squeeze. Does the bubble stay up there when I let go? Whoa, that means you are, well, too much tone, too tight. So you're not performing the exercises efficiently. That's when we need to do other things, relaxation techniques, deep breathing, diaphragm, to to relax your pelvic floor. Then you'll see that little knob come back down. Efficiency has to be efficient. So there's gizmos out there. Do you have them? The weights and something like this that I will often use. Sometimes I will use electrical stimulation to help muscles get activated. There are things to do. So I think at this point, last it again, just on your pelvic floor muscles, what's their job is, what are the issues? Support. We talked about that in me. That's why your posture is so important. Posture is so important. They have the support. That can help with the issue of prolapses. In coordination of these muscles is what I look at with biofeedback. Are one muscle's, pushing too hard, the other muscle's not doing enough. There's an incoordination of activity. The hypertonus, increased tone, it's like muscles are all up here. Some people keep their stress in their necks or maybe their back. A lot of us keep it in the abdomen. When you're really stressed, does your tummy hurt? Or do you have to have a big bowel movement? Anything like that, it's just tension. That's the hypertonus. And then there's a visceral component, meaning like the visceral component has to do with the loss of the mobility of the organ. Maybe there are adhesions from a surgery, or just tissues are sticky, gooey, tight, again, from your posture. If you're just constantly leaning over, things get adhered. So the viscera can also be impaired with that. I think right now, let's go back to the biofeedback, and I'm going to show you a little bit of exactly what I mean by how we are looking at that. I think it would be enlightening for you just to see what that looks like. And I did put in your handout a paper that talks a little bit about what that is. This is my software program for biofeedback. Biofeedback is in our lives in so many ways. Some type of stimulus and you get a response. I'm going to give her a stimulus. We're going to get Amy to work on her pelvic floor muscles. It's kind of thin, but the blue line above, if you can see that kind of going through, that's her pelvic floor right now. Because I put her sensors right on either side of her anal opening where the muscles are at the most prominent part. This is her abdominal muscles on the bottom. So when I ask Amy to give me a contraction, I'm going to see if her abdominal muscles... All right, I'm going to pause right now. So my instructions to Amy will be, contract as if you had stopped the flow of urine. That's the U. Contract as if you stopped the flow of urine. And let's see how... She's not done this before, okay?
It's the first time, so...
Yeah.
Okay,
She's
see
just...
if I get the right muscle here.
All right, you squeeze. Now let it go. Let it down. Oh, nice letting down. Give me a V, a vaginal. Squeeze in the middle, and then let it down. Nice one. This is measured in microvolts, so I can see how much energy she's putting into this. Not a measure of strength. It's energy. Give me an A where you squeeze as if there's gas. Come on, give me a best one. Give me the best one. Give me the best one, and then let it down. Great. Up on the board here is what's normal. On the side is microvolts. So someone starting at 0 all the way up to about 20 microvolts. It's the energy in the muscle that I'm measuring. It's how alive it is. Is it burdened? Is it inhibited from something else, maybe pain? That I'm going to be able to tell that. And so how well can she relax when I tell her to stop, let go? Some people, you know what rough idling is? I used to have a Ford. I'd turn off the ignition, it would still go. I call it rough. When I say let go of your muscles, and then sometimes it just doesn't want to let go, and that's muscle activity. Okay, Amy, since you're doing so well. All right, here she goes. This time, let's see if Amy can hold for 5 seconds.
Uh-oh.
Now, I'm going to want you to do all of them, U, V, A, right in a row.
Okay.
You do it with us, okay? Find your U, try your V, and then A. It's like 1, 2, 3.
Okay.
UVA. 1, 2, 3. All right. And then you're going to hold 5 seconds. Ready?
Okay.
Give me the UVA. Hold it. 1, 2, 3, 4, 5, and then let it down. This is beautiful. This is beautiful. This is beautiful. She got up to almost like 30 microvolts on this. This is just great. You passed. So we have a really nice rise. We have a good holding attempt, and then the coming down is just as important as the hold. So when I have the advantage, and see her abdominal muscles, only when it came down I got like an aftershock, like, ugh, I finally let go. So I can see that her abdominal muscles stayed quiet. If I could have put that electrode on her glutes to see if the glutes were trying to help, I could put it either way, or adductors. But I'm choosing abs because that's more than likely that's the case. This time I'm going to have you do the contract, but contract your abs with it as well, okay? All right, give me a UVA. Come on, Amy. Come on, Amy. Come on, Amy. Tighten your tummy as well. Oh, see the tummy helping, and then let go. Let go, let go, let go, let go, let go, let go. See, she's not wanting to let go so much. It wasn't a nice drop.
Right.
The abs interfered with the efficiency of that blue line of floor. So they take over. You think you're working the bejesus out of your pelvic floor, but you're really doing your abs.
Yeah. I felt a difference that time.
Yeah, you felt a difference in your ability to hold. And I can see you were having a hard time holding there. Yeah. So I put this information together with what I feel manually inside, and I get a good objective idea of where are you and how can I plan for your program that you will succeed, right? And that's the level of thoroughness that I want to do. And so the biofeedback program helps me to do that. And I use it for just about everybody who has a pelvic floor issue.
In massage therapy, we talk about sensory motor amnesia.
Mm-hmm.
Almost like the awareness isn't there.
Exactly.
And you can
exactly
paint a picture
It's right.
on the wall,
Right.
but people are just like numb. Or
They are numb.
They can't.
They just like, what?
The
What is it
nerves
you
are
want me to do?
halfway
Yes.
dead, or-
But if you are, like I said, if you don't have a neurological disease, you didn't have a stroke, then there's no reason why you can't wake it up, find it. It's just like it's on break. It just doesn't know what to do. And so you go to the core classes and Pilates and things like that, which is supposed to use these muscles as well. They automatically engage. But if these guys are having lots of trouble just doing it specifically, they're not going to engage as well with all your core work. That's my point. So it is correct that they will automatically engage when you start doing your core, your tummy work and all like that. But they've been under a duress, they've been inhibited, and we need to find them first, use them, wake them up, and then I'm going to put them together with your other core work. But I like to know, I really want to know they're there. They are working. They're going to give me the full amount that I'm asking for. Then I'm going to feel very good about sending you home and say, now you're going to do all this other abdominal work, your core work, maybe strengthen your glutes, all those kinds of things. But if you've been having issues for a while, meaning your frequency, urgency, or stress incontinence, or even pain issues, pain on intercourse, or just pain like, or heaviness, or maybe you do have a prolapse, or there's so many things that can go on with a pelvic floor issues that I kind of have to look at all those things as a provider, look at all the things that are happening for you. So I have like 100 questions for you. And then let's just see where you are at that point. What do you need to take care of first? What do we need to do second? What do we need to do third? And then what's the end goal? Well, I want to be dry. That's the end goal. I want to be able to go for a long walk and not worry. I don't want to have to do just in case before I leave the house. I don't want the key in the door syndrome. So there's a whole list of those sort of things. The last part of this is I do have some people with constipation issues, And I do have some ladies that have a fecal incontinence. You know, that is just really, really hard. They're embarrassed. They just, it seems like it's worse than urinary incontinence. So they do wear pads. But there's a strong correlation between having constipation and then later in years, oh my gosh, you're wiping and there's fecal material that you didn't even know was there. You had no idea that there was seepage or soiling. And you just, what's happening? It has to do with the integrity of the muscle tissue, not being able to hold it all back. Sometimes the urge for that, for fecally, is also very, very strong, you know, and it just will, you're not at the commode yet, and you just feel like it's, that urgency is so strong you can't get there. But what I want to address is the seepage. I'm going to call it seepage because you don't even know that it's there. Inside your rectum, anal canal, you have sensors. And those sensors tell you whether it's gas, whether it's diarrhea, or whether it's a formed stool. They tell you that. If you're tuned into all that, they tell you that. And so, but what I'm talking about is unaware that you have the seepage, and you just know that you do when you wipe. You know, what is that? And that is a function of a laxity of your sphincter muscle. Pelvic floor is not working as strong as it can. So, you know, by the time you take food through your esophagus, it runs through your esophagus, it's there about 6 seconds before it hits the stomach. In the stomach, it's churning and treating everything, kind of mashing it down. And that could be another couple hours. By the time it runs through the small intestine is what, 15 to 20, it's 100 miles, and 15, 20 feet by time, and that's where absorption takes place. And this is where we have a lot of gut issues like celiac disease and things like that. So then finally, what's left gets dumped up into the colon, all right? And then it works its way. If you have good peristalsis movement in your colon, it just pushes a little bit to get to the rectum and the anal canal. The literature out there say this whole process between the steak dinner that you ate, or the seafood, whatever you ate, can be another 24 to 48 hours before it actually leaves. It depends on your system, okay? It depends on how well hydrated you are. It depends on what drugs or medications you're taking that might slow down this whole process. So you can count on that let's just say normal movements are every day. Some people's normal, though, is multiple times a day. Like every time they urinate, they also evacuate. That could be normal for them. Other people, it's every 3 days. That's their normal. But according to the literature, it's anything longer than the 36 hours, 3 days. Is that 36 hours? 72 hours. Thank you very much. If anything longer than that, then there's a problem. So the longer the hard stool sits in the canal, it takes up space. What's right next to it, what's right in front of it is your bladder. So let's just say you've got this stool sitting there, taking up space, more comes down the pike, and it's pushing on the bladder. Bladder's not going to like that. It's going to be irritated by that. It's a highly, highly sensitive organ. And so keeping yourself flowing, keeping yourself, everything moving. When you have a bladder issue, even frequency, it's really important that you look at your foods. And I made a list back there of some good fiber foods in your handout, that you consult a nutritionist if you say, I really need to get a handle on all of this. Maria does lectures here a lot about gut issues. So you consult about what should I be eating, because I'm dealing with trying to get back to normal with my bladder habits and my bowel habits. But I just want you to know there are women out there who are suffering with the fecal incontinence as well. And you can do something about that. I have one lady now who's had the problem for a couple of years, and she just has to wear a diaper all the time, and we've been working together on the biofeedback, on strengthening, and I let her go for a month, and she came back, she had not one incident of the soiling, the seepage. And training your bladder, training these muscles can take 9 months. It can take a long time, because guess what? You're still living life every day. You're still doing things. You're still stressing your abdomen. You're still doing a lot of things. And that's what you should be doing. But what you're now doing is putting into the mix of how to work with these muscles. So there is hope. There is definitely ways to improve this. There are a lot of little, I'd say there's a lot of little, there's complexities with it. It's never just a straight shot. But you can do a lot of good things with just finding your floor. Your U, your V, your A. Work it. Work it. Work it. And I recommend starting off doing that. Then as you feel like, oh, I really feel it now, I really feel that I can lift my floor, then you start adding a time frame to it, like 5-second hold. These pelvic floor muscles have certain kinds of fibers too, that you have your fast twitch fibers, and then you have your slow twitch fibers. 75% of your floor is the slow twitch fibers, because when you put the key in the door, you're gonna, I gotta hold it till I get there. You want endurance, because you have to support everything. The fast twitch fibers is quick closing, quick closing. I didn't test it on Amy, but that's the one that you want to also engage your ability to quickly shut it off and then hold till you get to a bathroom. So you can do this. Just take these pieces of information with you. Go back to your doctors and say, this is what, make your list of questions. This is what I really want to get a handle on this. I don't care how old you are or when this started. You can still do some awfully good things to make it better. None of us want to get admitted to the nursing home, because it's primary reason why women get admitted to a nursing home, because the family doesn't want to keep changing the diapers. And so that's the primary admission document: incontinence. Family doesn't want to deal with it. So they send you to the nursing home. But you can be 80, 85, whatever, and still have control of your bladder, control of your muscles. They can be better. They can be better. There's no doubt about it. And then, so if you have this information and you have questions, you can ask your doctor about it. See a good pelvic floor physical therapist to help you with advancing your program, or custom make it for you. We've had some questions in between time about Total Recovery, Dr. Kaplan's book. It's just an amazing, well-written book about chronic pain, which is what we do here. And I invite each of you, if you know somebody that's suffering with pain like a long, long, long time, tell them to go on Amazon. I've even seen this in Barnes & Noble. Get his book. It's written, everything is written that you can understand it. He gets into the whole neurophysiology of why the pain keeps coming. All of us know people who have been in an auto accident 5 years ago, but they still have pain in their neck. You can well fix the physiological problem. Pain is still there. And I'm not saying it's all in your head, that kind of, that statement, but there is a reason why the pain isn't shut off. It's upregulated. It's just hyper, all right? And we have to find ways to deregulate that, bring it down. And his book is talking about that. I'll tell you the story of my daughter meeting with some of her friends, and she was telling her what their mother does, me, And I work at this pain management clinic with Dr. Gary Kaplan. And they said, well, who is Dr. Kaplan? What does he do? What does he do that other doctors don't do? How is he different? Why is he special? That kind of thing. And my daughter just out of her mouth said, well, he does more than having to look at you sitting on that treatment table. He looks under the hood. I don't know whether Dr. Kaplan really liked that or not, but anyway, I thought that was pretty good. There's a lot more to us than how we present. And so that's his job. He check everything. So it's a good read. Thank you all so much for coming and joining me today. I had a lot of fun with you. And I just appreciate you coming, and I hope I answered some questions and maybe sparked some new questions.